All right, good morning, guys. I think you guys are getting there. You're gonna start testing here this next month, right? Getting through it. Sounds like it's been a long class, but hopefully you guys will all be there soon. Sounds like you guys are starting clinicals. Go ahead and write in if you have any questions for me. Try to be, I like an interactive class, so it's going to be, like I said, a little hard with just one person right now, but you guys online, please feel free. I'll be paying attention to that chat box as much as I can. If you have my cell phone and I'm missing it, just shoot me a text. So, environmental emergencies, when I was looking over this, it seemed like a lot of it we kind of covered it, or you guys had kind of covered in previous chapters in different categories. Like there's some frostbite stuff. There's electrical injuries. I know we covered that a little bit in soft tissue injuries. Scott Oliver already left. I'm not doing so good, I guess. But so yeah, there's like 110 slides, but they seem pretty redundant. So we're gonna get through those. If I'm going too fast on anything, just let me know. But like I said, a lot of this stuff is not a big jump from your current advanced level coming from the basic. So um, we'll get into a little bit of treatment for the advanced level, but it's not going to be anything huge. So with that said, let's just start it off a little relaxed with a quick little video. So we're going to be getting into hypothermia, so I figured this is appropriate. Thanks, Ryan. Sorry about that, guys. Make sure. All right. So yeah, sorry guys, real quick. We are going to cover some of the submersion incidents, temperature-related, hypo. Is where bites. We talked about spider bites, snake bites. Not super common, but you can see them. We'll get into this stuff in detail as they come across. We've already been over electrical injuries once, I know, and soft tissue injuries, but we'll hit it again. Radiation exposure, again, it was hit in soft tissue injury, but I'll go a little more in depth. So environmental emergency is a medical condition caused or exacerbated by weather, terrain, atmospheric pressure at high altitude or underwater. Medical emergencies can result particularly in children, older people, people with chronic illnesses, young adults or who overexert themselves. And we'll talk about that as we change, right? As we start younger, as far as body surface area, as we're still like hypothalamus is like our thermometer in our body. It's our regulator. So that changes as we get older, and as well as our body fat content. So that's why what we can or can't tolerate temperatures as we get older. So we'll get into that as we talk a little bit more about hypothermia. The environmental effect on morbidity and mortality increases with stressors that induce or exacerbate other medical or traumatic conditions. So body works to ensure balance between heat production and heat exertion, thermoregulation. So that's that hypothalamus that I was just talking about. A rise in the core body temperature elicits responses that increase heat loss and shut off normal heat production pathways. Thermogenesis. Anytime you see these terms, like I said, write them down. They're great test questions that they like to throw at you on the National Registry. So, as you can imagine, break down the word, whereas like a decrease in core body temperature, lysis meaning that decrease or take away, prompts heat production and conservation and turns off the normal heat liberating pathways. So we talked about physical factors that affecting exposure, your physical condition, your age, nutrition and hydration, and environmental conditions. When we are trying to fight hypothermia, our blood shifts to our core, right? So if we're kind of low on volume, that's going to affect that heat regulation. Normal body temperature must be maintained with a narrow range for body chemistry to work efficiently. So typically, what's a normal body temperature? Yeah, 98.7, 98.6. Our body really doesn't stray too far from that if it's acting appropriately, but the way it maintains that could take more energy depending on the exterior conditions or medical issues that person might have. So doesn't take much to many degrees to make us too cold or too hot. So it is a pretty narrow range. Hypothermia, entire core body temperature falls because of inadequate internal heat production, excess cold stress, or a combination. We're going to talk about the different ways how we're our body defense to combat hyper or hypothermia. So conduction, convection, evaporation, radiation, and respiration. So let's see if we get into, if they break this down, and then we'll break it down. These are the type of questions that you are going to see. So making sure we have a good understanding of what it means for conduction and convection as far as body heat loss or gain. So the rate and amount of heat loss or gain by the body can be modified by increase or decrease of heat production, moving to an area where heat loss is decreased or increased, and then wearing the appropriate clothing for the environment. So So let's talk about conduction. Can you give me an example of like conduction? Yeah, so physical contact. And a common example is if you're like even cold air moving across the skin. Okay, creates whether it's cold or hot. That's an example of conduction. What about convection? Yeah, that's more convection. I apologize. So conduction, transfer of heat to water through touching of the skin, but convection is that air movement by the skin. Sorry if I confused you guys there. Does that make sense? Okay. What about radiation? Yeah, exactly. Like fire or just even from your body itself giving off heat. So not complicated, but you will see it on the test. So here's a wind chill chart. It is kind of interesting. If you look, you can have a temperature of 7 degrees out, but you add uh, five. Let's say you temperature is 5 degrees. You add a 5 mile an hour per wind speed. Now you have a -5 degree wind chill. If you look at those colors, that tells you about how long you can sustain that current temperature until you're basically going against cold injury. So you only have about 30 minutes in all those blue areas, and then 10 minutes, and then going down to 5 minutes. Same thing, but this is talking about kind of heat when you can have 90-degree weather, but a humidity of 80%. Now that feels more like 113 degrees. We do pretty good around here. We're kind of like right there in the middle. It's not super dry, but it's not super humid. So, you guys know what our humidity typically is like in the summer? Yeah. Yep. 70 to 80%. It's pretty common. So, hypothermia classified anytime the body temperature goes below 95 degrees Fahrenheit. Obviously, can develop either quickly or gradually. Alcohol is a common contributor to hypothermia. It kind of gives us that false sense of feeling that we're warm, but it's actually thinning the blood and causing us to be quicker to lose our body heat. Impaired thermoregulation can occur with therapeutic use or overdoses of sedative medications. So this is just kind of giving us that range of a body core temperature and signs and symptoms and the level of consciousness. So 95 to 93 degrees, it's going to be really hard for us out in the field to even get a true measurement. Our current thermometers from the dollar store, so it's kind of even hard to regulate. In hospital, they can do core temperatures, whether it's down the esophagus, rectal, just depending how they want to go about it. Hypothermic patients, be mindful that we're not just talking about winter. We can be in the spring. We can talk about picking up a hypoglycemic patient in the front yard at 8 o'clock in the morning. You have to start thinking, well, how cold did it get last night? How long has this patient been laying there? So they can be going through the stages of hypothermia, and how cold they went, may depend on, did they get to the point where there's cardiovascular effects because those electrolytes and the potassium will stop working. So stop working as well for that sodium potassium chump in the heart. So getting them on a heart monitor and taking a look at their heart rhythm, understanding that drugs may have a delayed response, as well as, in that scenario, if you fix their sugar but they're still altered, you may be looking at, a core temperature of 92 to 89. So that has been patients I have seen in the past. Local cold injuries. Injuries from cold are localized to exposed parts of the body. In systemic hypothermia, blood is shunted away from the extremities to maintain the core temperature. So let's talk about that. When we become hypothermic, what happens? How are we shunting blood? What's going on? Okay. So it's our first mechanism, but how is it doing that physiologically? Yep. So it's going to constrict vessels to bring blood back to the core. And then how can our body generate heat? Right. So it's gonna the body's gonna start to shiver. Okay. So now we're consolidating blood flow back to the core, and now we're gonna start generating heat. So we're gonna start shivering. During the hypothermia, the norepinephrine surge. There's 3 stages. The norepinephrine surge is just that, where we vasoconstrict, we become tachycardia. And then if we continue that hypothermic state, we're going to go into a norepinephrine decline. So we have a surge, and then naturally we're going to, at some point, no longer maintain. So we're going to have a decline. At that point, you're going to see tachycardia to bradycardia. So just kind of comparable to our compensation and decompensation shock. It's the same scenario. You saw our heart rate make up for it to increase that blood volume. Now we're going into bradycardic rhythm because it can no longer maintain. The third phase of that is going to be cardiac receptor dysfunction. So you're going to come across someone who's hypothermic. You're going to see them in that bradycardic state. You're going to say, oh, our paramedic should give atropine. We're going to give atropine, but then all of a sudden it's not going to work. It's going to be, you're going to be kind of puzzled if you don't understand the physio effects behind it. But when they get to that point, the alteration of electrolyte movement is affected. So we talked about how important electrolytes are in the body for the sodium and potassium to work. Well, those start leaving the cells. They go into the extracellular space, and so we're no longer getting that exchange. So it's a delayed response. So our cardiac drugs are going to have delayed response. Anything basically you give these patients are going to have a delayed response. So you want to give something like a atropine. Well, you can give it and hope that it works, but it's either not going to work or it's going to take some time. Biggest benefit we can do is start warming the patient back up through passive warming. So cold exposure, injuries. So we got frost nip. I don't even know how to say that. Chilblains. Yeah. Immersion foot can result when exposed parts of the body become very cold and not frozen. You can hear different terminology, whether it's deep tissue or superficial. Obviously superficial just meaning just that, it's just on the top layer of the skin, but as you get into that deeper tissue, you're going to obviously see a lot more injury, and that's when you're going to start seeing it go into that white glossy phase and then into the black. Often affects the nose, fingers, and is not painful. So just like we talked about, because of shunting, the body's okay with losing a nose, losing some fingertips and stuff as it vasoconstricts and puts blood volume into your core. That's also why when people are cold and starting to go into that hypothermia, that's why you have to pee a lot. because there's more blood flow to the core, which puts more blood flow into the kidneys, which the kidneys think, oh, I have all this extra blood volume. So then it obviously starts excreting it to the bladder, and then we pee more. So that's early signs, hypothermia, and that now that patient's becoming dehydrated. So whether it's just you out there ice fishing or hunting, you got to stay hydrated. But think about that for your patients. They're becoming dehydrated on top of hypothermia because of that. So, frostbite. Tissues are frozen, permanently damaged cells. If gangrene occurs, the dead tissue may be surgically removed. It can be identified by the hard waxy fill of the affected tissues. So, when you're getting to this frostbite, we're looking at these cells starting to burst. Where they're starting to excrete all their contents, those the fluid, and that's why you're going to start seeing those appendages swell, because it's all the fluid going into that extracellular space, and then it's basically dying. So these assessments, as you guys have probably picked up, I mean, they're they're about the same, right? They all say ABCs, and then for this one, prevent further heat loss. So kind of just no-brainer stuff. Yeah. Mm-hmm. Yeah, absolutely. I think right after that assessment, Warren, we're going to get into treatment, and we'll hit that. Okay. So we're not going to spend time. I know you guys know that you guys should ensure that the scene is safe for you and other responders. Okay. Yep. Look for mechanism of injury, form of general impression, rapid full body scan, AVPU. Yep. You guys know all this. So if you believe the patient is in cardiac arrest, proceed directly to the circulation step by providing high quality chest compressions. Okay. So it is for us out in the field, we need for patients to be clinically dead, they have to be what? Warm and dead. So this is going to be one that you guys are going to have to use a little bit of your critical thinking, and then get in medical control. If you truly do have a feeling that this patient is dead, then better to pass it off on medical control. Otherwise, you guys have that liability to get them warm, work them as a full code, and until they're warm and you've done. Once they're warm and you've done 20 minutes of CPR, then we can look at calling it. Any questions about that? So as we're going to get more into those treatments on these cold patients, everything's kind of delayed. So remember too, if it's cold water immersion, patients can last a long time. I think 52 just a couple winters ago pulled someone out. I want to say after 27 minutes under, and they had no neurological deficits when they did achieve ROSC, and that patient walked out of the hospital with no deficits. So. Yep, history taking. Like I said, if I don't think any of this is new to you guys. So if anyone say, "Hey, slow down," but you guys already know, get a medical history. Yeah, determine duration and temperature exposure, wind velocity. If you guys can determine wind velocity and let the doctor know, sweet. So patient's last oral intake and activity prior to the exposure will help determine the severity of the cold injury. Sure. So exposure to wet conditions, fatigue, and age. So wet wet, getting into the treatment side of things, wet clothing is huge. It's one of the like second fastest ways that the body's getting cooled. So we have to get that wet clothing off. It's the same thing when we do treat these patients. We're wanting to treat them with dry blankets, dry sterile dressings, because if you even get something wet and warm and trying to put it on a cold injury, it's going to cool down fast, and then it's going to start absorbing whatever heat or transfer of cold to that injury. So wet clothing and stuff and has to come off. Always consider other things on board, whether it's alcohol or previous medical conditions. So what are we worried about? Like, say someone's diabetic and now they're facing a cold injury. Yeah, and what do we know about diabetics and their vascular nature? It's already crappy. Yeah. So just uh, poor, uh, poor vaso flow, right? So because, like you said, those glucose molecules will crystallize, create damage in the peripherals. So now someone that's already have a cold injury, well, now it's going to take. It's harder for the body to take out the toxins, transfer that blood warm flow. That's why, like in the hospital, I mean, they're careful even clipping toenails on diabetics because there's such low blood flow that you create any kind of infection in your body has a hard time removing those toxins. So that's why a lot of times you see those patients that have amputations. Usually they're diabetic. So same thing with cold injuries. It's a very big deal for them. And you're going to see cold injuries in them a lot more in harsher environments than a normal person could sustain. So secondary assessment used to uncover injuries missed during the primary assessment. Focus your physical examination on the severity of the hypothermia. Determine the degree and extent of the cold injury if you can. Like I said, you find them in the morning. It's really easy to miss sometimes. You might feel them and be like, oh yeah, they feel cold, but like I said, they can be hypothermic. That core temperature can be extremely cold, and you got to be thinking, how long have they been exposed? So whatever you may be thinking is the chief complaint, really could be the hypothermia, and that you guys should be going possibly code 3 to the hospital. So we talked about that low blood pressure and slow pulse indicate moderate to severe hypothermia. The body's initial response is to increase the heart rate. So if you're starting to see bradycardia, you're going the other way. We don't have that ability to, as far as to determine hypothermia through a thermometer. We just don't carry those. Pulse oximetry will often be inaccurate because of why? Yeah. Anytime our body's cold or low perfusion, we're not accurate on that. So use skin signs. Look at the core, look at the face, put together a pretty good, a better idea of what you're dealing with. And then I always refrain. Just with normal patients, right, that have cold fingers, we're getting inaccurate pulse ox. And what's a good indicator on the monitor for us to know if we're getting an accurate reading? The pleth, right? We should see a nice, big, wavy, consistent form. Yeah. So I kind of refrain from even telling the hospital what their sats are if it's a poor pleth, or I might say unable to get a sat due to poor pleth. Otherwise, you tell them what it actually is, and they're wondering why they're not intubated or some stupid thing. So. Yep, reassessment, everything we already talked about. Yep. So general steps to prevent further cold injury. So we remove wet clothing, keep the patient dry, prevent the conduction, heat loss, insulate all exposed body parts, prevent convection heat loss by erecting a wind barrier around the patient, and then remove the patient from the cold environment as promptly as possible. So evaporation is one of the fastest cooling effects for our body, so we need to get them dry. Take away that any kind of wind or breeze for that convection effect. So lots of dry clothing. Like Warren, you had alluded to earlier, we want warm IV fluids. We're still going to go off our normal formula for fluid bolusing a patient, which is what? Yeah, 20 mils per kilogram. So for usually normal standard adults, I mean, you're going to be able to get a couple liters in. Any questions on that? We've got 11 slides getting into this care for cold emergency. So if something pops up, let me know. Yeah, so we don't carry humidifiers on our oxygen, but we'll just give them regular oxygen and it'll be fine that way. Talked about IV access and then administering those warm fluids. That is something that, especially this time of the year, to consider when you guys are out running around. Do I leave the ambulance on or off when I get back to the station? Do I take the time to plug it back in so we can keep those warmers going on those IV fluids? Other things to consider, maybe you have IV bags that aren't, or they're in a red bag with a patient that needs prolonged extrication, or for whatever reason, maybe you're going up the Fernan Pass and you're doing medical care out in the wilderness, whatever it is, and you just need to warm up the bag of fluid. Something I had done in the past on those kinds of patients is taking those heat packs that you have and wrapping your IV line around them, because it's a smaller volume and that'll heat up a lot faster. Wrapping that line around those heat packs, and usually too, I mean, there's whether you're around law enforcement and stuff, usually they have first aid kits with more heat packs as well. So go ahead, Warren.
Really be concerned with the rate of the fluid that we're giving at that point.
Do you need to be concerned about the rate?
Wide open.
Oh yeah, yeah. I would run it wide open. Yeah, I mean, you know, you're monitoring that blood pressure. You're monitoring the lung sounds, and then you're doing that. No, Warren's asking, should we be worried about changing that core temperature too fast? Not with IV fluids, and depending on the severity of the tissue that's exposed, if you're dealing with just more of a core temperature or you're dealing with frostbite, they're going to evaluate that. If it's just superficial, they're going to, at the hospital, they're going to be looking at putting them in a tub of warm water between 102 and 103 degrees Fahrenheit. So you definitely don't ever want to start re-warming a patient if you can't sustain it. So say you're dealing with someone out in the woods, you get called up to somewhere in one of the Coeur d'Alene National Forest, Fernan, like there's always snowmobilers that get stuck, accidents, whatever. You don't want to start rewarming that injury. So putting a heat pack on frostbite toes, fingers, if you can't sustain it, okay, it's going to make the injury way worse. So with that said, if say you're out in the woods hunting or whatever, and you're going to build a fire, same thing. You still have 2 miles to get out. Don't be careful if you're rewarming a severe cold injury. You're better off just to put dry socks back on, or try to get it dry, but try not to actively rewarm it. Never rub a cold injury, obviously. We don't want to break up all those crystalloids that we're forming. And again, remember when you're doing that fluid bolus, they're probably dehydrated at that point. Okay, they've been urinating a lot of their fluid. So we just talked about this. We're not going to massage the extremities. We don't want them to eat, right? When you eat, food goes to the stomach. It requires more blood demand. That blood should be saved for your more crucial organs. So. Mild, you're looking between 90 and 95 degrees Fahrenheit. He is me. What?
There's more to it.
Okay. Moving on. How are you guys doing? You guys getting there for a break? We'll finish these next 6 slides and we'll take a break. So now, when we're talking about moderate or severe hypothermia, I mean, that's serious. I mean, we're talking about below 90 degrees Fahrenheit. So this patient, it's that comatose patient. They're probably not talking to you. Pushed in the apartment. We talked about because they can probably sustain accurate warming temperatures. Extremities too rapidly without rewarming the core can cause vasodilation. If you cannot get the patient out of the cold immediately, move the patient out of the wind and away from contact with any object that will conduct heat away from the body. Remember that even an unresponsive patient may be able to hear you. So we've hit on this stuff. I know we talked about submersion preceded the rest, then successful resuscitation is unlikely. Trauma, alcohol overdose, and drug overdose could have resulted in hypothermia. We've talked about why that was, of thinning of the blood, and that patient just not being able to understand their environment as well because they're feeling good. So I'm not going to keep drilling you guys with all this repetitive information. So as I see something, I'll point it out. Yep. So again, it's just repeatedly saying remove wet clothing, don't rub the injuries. When you do get to that deeper cold injury, they do not want you to start rewarming that injury. So what are signs of that deep injury, the deep cold injuries? What? Waxy what?
Waxy up to the skin.
Yeah. Black, it can go from a waxy white. It's kind of both spectrums. It can go from a waxy white to now it's dying, and a very late sign is that darker purple black coloration. What's that? Yeah, not being able to feel it for sure. Yeah, and I mean that can definitely come with your earlier signs as well at the end of your extremities. So I don't see this being an option for us. But if medical control instructs you to institute rewarming in the field, you're going to use warm water bath. This slide, the literature is a little bit wider range. This one's saying 100 to 105. Other literature will say between 102 and 103. The only thing in this slide that we haven't already covered is it's talking about blisters. It says do not break them. Really, it's not a big deal whether they break on their own, if they're still intact. The biggest thing they're concerned is if they do break, it's just another site for infection. So. All right, we're going to be getting into heat exposures. Let's take 5 minutes, and we're going to keep drilling through this. I'd like to get you guys out of here earlier than sooner. I know a lot of this information's been repetitive just from the few classes I've already taught you guys. Go ahead and send in your questions during this break if you have any. Otherwise, we'll get going by 9. We'll go 9:55, so 7-minute break, and then we'll just get through this. All right. So just kind of talking to some of the guys here in class, it seems like your guys' book is 50% redundant. Seems like everything will tell you to scene safety, all the ABCs, talk about your assessment, your secondary, and then things that are hit in one chapter gets hit again in another chapter. So sorry about that. That's why we're just so heat exposure. We're going to get into that, and then talk about some altitude sickness as well as water emergency. So heat exposure. So again, our body's trying to maintain that 98.6. Body gets rid of excess heat through thermolysis, sweating and dilation. So we're kind of just exact opposite of the hypothermia. It's a higher core temperature, usually above 101 degrees Fahrenheit. Pathophys, we're talking about the mechanisms to decrease the body heat are overwhelmed and illness develops. High air temperature can reduce the body's ability to lose heat by radiation. Vigorous exercises causes loss of fluid and electrolytes. That's usually our number one patient. Are athletes or people working hard in the warm weather. Illness from heat exposure can cause heat cramps, heat exhaustion, and heat stroke. So what's the difference between heat exhaustion and heat stroke? Yeah, loss of consciousness. Guarantee you'll see that form of question on your test. So just knowing the difference. So again, just like most anything, the children and the old are at the highest risk. Patients with heart disease, COPDs, diabetes, dehydration, obesity. Patients with limited mobility. So preventative measures, common sense stuff, adequate fluid intake, acclimatization to the environment. When you change environments, so all of a sudden you go on vacation and you go from 60 degree weather and you're going to somewhere where, well, we even talk about, well, I'm not talking about right now, but there's times like when we want to get out of here by February, and we go somewhere where it's 65, 70 degrees, whether it's Hawaii or Mexico. We're walking around in shorts. all the locals are looking at us like we're freaking crazy as they're wearing all their big old jackets and stuff. But that's warm to us at that point. Same thing though when we go down New Mexico in the summer and it's 110, 120 degrees out, and people can still are out, they're functioning, they're working out in the fields. For you, you're doing a few hours of work and then you need to get inside and go take a nap because you're exhausted. Your body needs time to change. So acclimatization to the environment. Same thing we when I used to do wildland fire, we'd get called on a fire and maybe we're somewhere down south in the States and we've got maybe 20-30 minutes until we're going to get out of that vehicle. We would shut off the AC and start letting our body get used to the warmer temperatures before we open up that door and try to go straight to work in that hotter environment. So heat cramps, painful muscle spasms that occur vigorous exercise, usually occurs in the legs or abdominal muscles. Dehydration may also have a role in the development of muscle cramps. So, yep, you're looking at basically water and potassium lacking in the cells. So. Heat exhaustion, most common serious illness caused by heat resulting of the body losing so much water and so many electrolytes. Hypovolemia, which is obviously fluid depletion, occurs. Signs and symptoms: cold, clammy skin with ashen pallor, dry tongue and thirst, dizziness, weakness, faintness, normal vital signs, or slightly elevated body temperature. That's usually one of my first go-to patients to try to gauge dehydration. I ask them, open up your mouth, or ask them if they have dry mouth, and then checking skin signs. Those are early signs of dehydration. So regardless of, they say, most people say, oh yeah, I've been drinking my normal amount of fluid. Especially in the winter, people tend not to drink, they'll drink their couple cups of coffee, but then not hydrate with water just because we don't have that natural urge. Heat stroke, most serious illness caused by heat exposure, occurs when the body is subjected to more heat than it can effectively remove. Body heat temperature rises rapidly to a level which tissues are destroyed. Hot, dry, flushed skin. First signs is a change of behavior. Patient no longer perspires. So again, going back to that conduction, convection, radiation, what's the body's best way to regulate heat? Sweat, right? And then from sweat, it does what? Evaporation. So that's why when you're out there working out, you want to put water on yourself. You want to continue to sweat. If you become that hypovolemic, dehydrated person, you're no longer sweating. Your core temperature starts skyrocketing. So after the patient no longer perspires, what do you think are some of the next symptoms coming? Change in mentation. Weakness and fatigue. Yep. So with these patients, again, altered mental status, you always want to be looking at heat exposure versus jumping to conclusions of like alcoholism or alcohol or anything like that. So again, consider chronic illnesses with any of these environmental emergencies. So recovery depends on the speed with which treatment is administered. This is one that bringing down that core temperature should happen as quickly as we can. We're not really fearful of doing it too fast, too quick. With that regard, if you have something extremely cold and you start applying that to the extremities, that is something that you need to keep in mind. You can make someone with heat exhaustion shiver, so you do have to be mindful of that. But as far as just kind of just like cold injuries, you do want to remove any blankets, anything as far as conduction wise touching. You want to expose, and you want to, if you can, this is that scenario where you can apply wet cloth, because of that reason we talked about, evaporation, and then any kind of wind flow with water on will cause rapid heat loss, which is what we want in this scenario. So we're gonna get through these scene size ups and these assessment slides because they're pretty redundant. As things point out specific to this, I'll point them out. But you guys already know to look for indicators for mechanism of injury. This is probably about the 60th time you've seen it. So. Just that overcooling can result in shivering, which generate more heat. We are AVPU, yep. Treat the patient aggressively for shock, for signs of heat stroke, transport without delay. Yep. Maintain with medical history, sample, determine patient's heat and humidity prior to onset of symptoms. You guys okay with this? Yeah, you guys feel okay. Yep, we already talked about the muscle cramps, the confusion, obtaining patient's mental status and patient's vital signs. So with hyperthermia will often be tachycardia and tachypnic. As you bring that patient's body core temperature down, you guys can expect that to go down as well. So oral temperatures can be misleading. We may be going back to those, not sure yet, so just keep that in mind. All right, so treatment in the field. We want to obviously remove that patient from the hot environment. Administer high flow oxygen if indicated. Typically, I don't see it being indicated, but it is kind of one of those go-to for us in the field. If you don't know what to do or don't know what the answer is, I say put oxygen on them. I don't know why, but rest the cramping muscles. So obviously, just make them relaxed. Replace fluids by mouth. That is something that for most instances we don't give fluid to patients by mouth, right? This is one of those, give them water bottles. Let them drink fluid if they can keep it down. If they're past that point where they're vomiting, we're probably going to already be giving them fluid by IV anyway. But both routes are acceptable. So we're typically not going to provide cold water immersion to the patient if allowed, but obviously that's going to be one of the fastest ways because it is getting that water on the skin, as well as the cooler temperature all around the body. So transport to the hospital for more aggressive treatment. If the symptoms don't clear up promptly, level of consciousness decreases, body temperature remains elevated, the patient's very young, old, or has any underlying medical conditions. I think out there in the field, you guys are going to have a pretty good idea that if they're starting to become hypotensive, they're altered, I mean, we're going to be transporting these patients in. So we don't typically just give bags of IVs and then get refusals, even though a lot of patients think we can. So heat stroke recovery depends on the speed of the treatment administered. When treating a patient with heat stroke, move the patient out of the hot environment, remove the patient's clothing, again, administer oxygen if needed. Cover the patient in wet towels or sheets. Go back to that, just kind of that universal fluid bolus of 20 mLs per kilogram. Provide immediate transport to the hospital. You guys may get a scenario base when you do your IV in your national registry during your practical. A scenario could be a dehydrated patient, and they're going to tell you to fluid bolus that patient at the 20 milliliters per kilogram. So they're going to continue to beat this in any kind of slides where they want you to fluid bolus, and they're going to throw it at you during the national registry. So know it. Don't show up to the national registry not knowing how to give a 20 ml per kilogram fluid bolus to a patient. Like I said, a few weeks ago when I did help with the national registry, I had to fail 2 people because they didn't know the conversion. They didn't know how to go from pounds to kilograms and then give that 20 milliliter per kilogram. So don't be like that. So respiratory impairment from submersion or immersion in liquid. Patients with submersion injury can die of secondary complications that occur beyond 24 hours. There is that reflex as far as cold water of submersion that will create bradycardia and decreased respiratory drive. So when we do talk about cold water injuries or scenarios, we use that as that is a vagal maneuver. If you put your face in a cold bucket of water and hold your breath, you're on the monitor, you can watch your heart rate go from whatever 100 down to 40, and your respiratory drive is going to decrease. So it is a vagal response. So this is just talking about fresh amounts of fresh or salt water can severely irritate the larynx, resulting to laryngospasm, and it prevents more water from entering the lungs. That's why you can have like a diving reflex where your lungs are completely clear of water, but that patient drowned, but basically more from asphyxiation than it was from the water in the lungs because of that laryngospasm. So definitely, it's a body's defense mechanism, and it's kind of neat when you have someone under the water for a period of time and you can take them out and lungs are clear and you do that full CPR and you get them back. Just the body's way of protecting you. So we're getting into that diving emergencies and more of that barotrauma. So there's every 33 feet that you go down, you're having that increase of pressure. We're going to talk about a couple of those laws. So physical principles of the pressure effects. Scuba diving is done at depths between 30 and 60. What's FSW? Any diving guys in here? Oh. But 2 to 3 basically atmospheres. So feet of seawater. So for every 30, or other literature will say 33 feet, you're going to a whole nother atmospheric pressure. So that basically means your volume is decreasing by half, but your pressure is increasing by double. So that's why when you're coming up too fast, the volume is going to double, and if you come up too fast, it'll destroy the alveoli. So here's those laws. You got your Boyle's law, your Dalton's law, and your Henry's law. So your Boyle's law, it states that for every 33 feet below the surface you dive, the pressure of gas in your lungs doubles while the volume decreases by 1/2. So 1 liter of air at the surface is compressed to 500 milliliters at 33 feet below the surface. So remember the difference between these laws, because I do remember these laws, or at least one of them on my national registry. So it's a good one to know. The Henry's law states that the amount of gas dissolved in a given volume of fluid is proportional to the pressure of gas with which it is in an equilibrium. So since the body is made up primarily of liquid gases that are inhaled, they will be dissolved in the body in a proportion to the partial pressures of each breath. So the body uses oxygen, but it does not use nitrogen. Therefore, the primary gas dissolved in the body is nitrogen because it is inert and it is not used by the body. So at 33 feet below the surface, the quantity of oxygen and nitrogen dissolved into the tissues will be 2 times that of at sea level. So it's a lot of information right there. Yeah. My best guess is I'll kind of stick it to Boyle's law. I mean, to me, I think that's the more common. So dive tables and dive computers provide guidelines for divers regarding when to take decompression stops during the dive. I have yet to have to deal with it, an emergency with a dive patient, but I know they do dive classes in Coeur d'Alene. I'm sure there's plenty of people that'll go dive in the Spokane River. So it's just something to keep in mind that they're coming up too fast. You could be dealing with respiratory emergency because of the expansion of that gas due to Boyle's law. I don't know if it's going to get into it, but also keep in mind that when you're talking about, it'll probably fall under that Henry's law. Those gases can expand in that interstitial. So anywhere you have this small vasculature, like in your brain, coming up too fast and that the nitrogen expanding can cause ischemia around small vessels. So you may see someone come out and have like stroke-like symptoms. So keep that in mind. So we're kind of back now to that the common thing where we're talking about assessment. They want you to do a full pertinent history, when did the symptom starts, what type of diving was done, what type of equipment was used, where was the dive site, what was the water temperature, was there any other dive complications. So phases of a dive: descent, bottom, and ascent. Major problem during the descent is your barotrauma. A person with a perforated tympanic membrane, talking about the eardrum, may develop a special problem while diving. So about every like 7 feet, you need to decompress, clear that air pressure. Let's see. You guys have a couple in your department, a couple new guys, right? That were divers.
Well, there's people who do it for hobbies, but
Okay.
diving through.
Right. I thought you guys had a couple guys in the military doing diving or something like that, but
I don't have people who dive.
yeah, sure. Sure. All right. So nitrogen narcosis is caused by breathing compressed nitrogen containing air at depth. So ascent emergencies, this is kind of getting back into what we just talked about. Usually requires aggressive resuscitation. 2 particularly dangerous medical emergencies are air embolism and decompression sickness. We don't have any of those barometric capsules here, but they do have them in Spokane. So that might be something to consider. Calling into the medical control and seeing if we should skip Kootenai Health and go straight there, or if this patient should be flown. So it can cause pneumothorax, medial ostinal and subcutaneous emphysema, alveolar hemorrhage, and lethal air embolism. So we kind of talked about as that air expands in your lungs and puts more pressure, it can destroy those alveoli. Yeah.
So for those that have never been there, the hyperbaric chamber is north of, just across the street north of Valley Hospital.
Okay, so hyperbaric chamber is just north of the Valley Hospital.
And they have two chambers, one that sends in multiple people and then one that's small, more individual basis. And they need advance notice. So if you feel that you're going to go that route, contacting them early to let them know that you have an emergency patient is in your best interest. You're going to have to try to manage that patient while you're there because it's essentially a doctor's office.
Okay.
So I think it takes like an hour to get the pressure up and down. So.
Yeah, that's good to know. So Taylor was just saying those hyperbaric chambers do take time to work. So giving as much advance notice to that facility is going to be an advocate for our patients. Has anyone in this room had to deal with a patient yet with these barotraumas? Okay. So again, we have guys in the water all winter long, scuba diving here, doing dock works, things like that. So it can happen at any time of the year around here. So people with COPD and asthma are at a slightly increased risk. As we know, some of them already have, like the COPDers, can have already damage to the alveoli. So physical examination may reveal palpable subcutaneous air above the clavicles. So basically those Rice Krispies, right? You're looking for the popping, those little air bubbles. You can get them in those intercostal muscles as well. Look for unequal breath sounds, low pulse oximetry values, and hyperresonance on the affected side of that chest. So, yeah, making sure they didn't burst one of their lobes of their lungs. A pneumothorax may require needle decompression or a chest tube. Air embolism, conditioning involving bubbles of air in the blood vessels. Air inside the lungs expand rapidly. Air released from this rupture can enter the pleural and compress the lungs, enter the mediastinum, and enter the bloodstream and create emboli. Pneumothorax and the pneumomedia, man, they're just going to keep throwing this word at me. Pneumomediastinum both result in pain and severe dyspnea. So again, signs and symptoms of air embolism, we're talking about mottling of the skin, froth or pink or bloody sputum coming out of the nose or mouth, severe pain in the muscle joints or abdomen, difficulty breathing, dizziness, nausea, vomiting, difficulty speaking, coughing, cyanosis, difficulty with vision, irregular pulse, or even cardiac arrest. So air embolisms, usually they come on acutely, and they can be anywhere from small to big. Someone can have that pinpoint pain somewhere, or that person can be like they said, pale, diaphoretic. They're working hard to breathe, and they're gonna die quickly. That decompression sickness occurs when bubbles of gas obstruct the blood vessels, result from too rapid of an ascent from a dive, too long of a dive at too deep of a depth, or repeated dives within a short period. Do you guys see this or have an idea of this decompression sickness with divers that do something too soon? They fly, right? They're not. I believe it's supposed to be like 48 hours, 48 or 36 hours. Yeah, before they're supposed to get on a plane. Give that body that time. Otherwise, you're going from 2-3 atmospheric pressures below to now you're going multiple above. So. Dive tables and small diving computers are valuable to calculate and record the proper rate of ascent from a dive. So here's a hyperbaric chamber. Air embolisms occur immediately on return to the surface. Symptoms of decompression sickness may not occur for several hours. And then treatment consists of BLS followed by recompression in a hyperbaric chamber. So they're going to put them right back down at that atmospheric pressure that they were at. So that's when that pertinent medical history of asking, hey, what depth were you at, and kind of relaying that on to these staff so they can put them back at that atmospheric pressure and then slowly bring them back. All right, so moving into, are you guys doing okay? Okay. Water rescues. It's kind of we all know this acronym, reach, throw, row, go. Did you guys do Coeur d'Alene guys? Did you guys do ice rescue this fall? So we're all familiar. So for cold areas, plan for ice rescue is also necessary. Success depends on how rapidly the patient is removed from the water and ventilated. Ensure to get immediate access to the personnel, floating devices, and other rescue equipment. Remember, there is that body response when you go into cold water of that bradycardia. So these patients may not last long when they get introduced to that cold water environment just because of that vagal response from the body. If we hold on 1 second, let me double check something. All right, let me get back. So the sheriff or accumulation of the law enforcement around here do have the dive team. So we're obviously responsible for everything above the water, and then they're responsible for everything below the water. What are some things to when you guys are thinking about recovery techniques for our local area? What are you guys thinking? So recovery techniques and things to have ready. We're talking about patient care here. So when you've got a crew out there bringing a patient to you, what are things that how are we going to treat these patients?
Backboard, and then typically not close to road access, so having a litter nearby to get them from the water to the ambulance to start actively warming.
Yeah, so backboards, having litters. Normally we're dealing with embankments, trying to get up. And then what was that last part you said?
Getting them to the ambulance to start stripping clothes and actively warming.
Yeah, actively rewarming, because depending how far they go down, it can be the middle of summer, but that bottom water, you get down 20 feet, you're now looking, easily 40 degrees, and getting down to 30 degrees where it never changes, or at 30 feet, you're looking, closer to that.
Even summertime here, our water still classified as cold water. It doesn't reach above 70. So if the air immersion part, it's a cold water drowning.
Yeah. Yep. I agree. So same theory. Any drowning, consider cold water. And then so when we are dealing with resuscitation efforts, rewarming, getting that the back of our calves as warm as possible, and then and blankets.
Josh, what's the link to as far as jostling these patients who are possibly been exposed to cold and a hold of them safe?
So yeah, what's the validity because we talk about we're not trying to be vigorous with these hypothermic patients, but then how do you do CPR and not do vigorous handling? So I think it's just all the best you can. Obviously you're trying to warm these patients up, but you're not going to start rubbing those extremities and loosening up all the crystalloids that have formed because of the cold temperature and lactic acid. So you're just doing what you can, Taylor. I think obviously once you achieve ROSC, it's just something to know. We're not going to jostle them as much as we can. So it's a good question, and I think it's something that I've seen presented to medical to doctors as well, and it's just a common request. But you're gonna obviously take priority for it first.
We had one of these this winter, and I know Ryan and Robert were both in suits in the water. Do you feel like it was necessary to help them because they were pretty far out in the water? Do you think you're going to usually get them back to shore quicker than just the diver?
Yeah, for sure. Super fast.
I mean, if there's two divers in the water and you've got a large adult, it's not very easy to drag them in their scuba gear back to 50 feet out in the water.
Shore, up onto a boat.
We had two of our people in Mustang suits, but
Mm-hmm.
you just gotta make sure it's not people that have to quickly get an ambulance. And they were just basically workers handed them off, and then people carried them the rest of the way, 100 yards up the bank to the ambulance. And then for that one, we had a pretty good time clock of exactly when they went in the water, so we could pass it all on. But it was like 40 minutes or something. In the water, maybe,
So yeah, 40 minutes under the water. And did they get ROSC on that patient? Don't believe so.
They had some activity, but never lost.
Yeah, and I mean they've you read case studies of people being under the water for 45 minutes and them getting ROSC. So I mean it's all back to that warming up the patient and working them until they're warm and dead. I mean they've got good survival rates because of that laryngospasm, that body mechanism to keep water out of those lungs. And then you have all those colder temperatures rapidly on that patient that's slowing down their metabolism and the release of that lactic acid. So kind of just putting that patient in that still state so they're ready to go when you rewarm them and you're doing those resuscitation efforts. So definitely be aggressive with it and try to get them to the hospital in those scenarios, in my opinion, because a lot of those scenarios with cardiac arrest, we're working them on scene and calling it 20 minutes. I think those are ones that are appropriate where you're a little more aggressive and at working them and getting them to the hospital. So on these drowning patients, scene size up, this stuff you already know, but you're going to make sure the scene is safe. You're going to be looking for hazards. You're going to, in our profession, we're talking about if you're near the water and life jackets and not becoming a victim. If you can triangulate that patient or talk to bystanders last time seen and, use them to stay on the shore and point where they saw them. And if someone else in another location on shore saw them, you can use that to triangulate them. Losing those patients of where someone thought they saw them go down can be different, especially if we're talking about Spokane River and knowing underwater current flows. Locating them can be difficult. So assess life threats and determine final stabilization is necessary. Pay attention to chest pain, difficulty breathing, sensory changes, AVPU, suspicion of alcohol, kind of the same bullet points that you guys have seen 80 times. Airway and breathing is going to be big on these patients, so be aggressive. You guys, if they don't have that gag reflex, you guys can go with your supraglottic airways. So, and we did determine that you guys can do soft suction. I believe I cleared that with Scott. So keep that in mind. Yeah, no gastric suctioning for you guys, but you guys can, can do soft suction. So as much water as you can get out, the better for that patient. they're going to develop pneumonia. These patients that do get water down in their lungs, it's especially if it's Fernan, they're going to get probably some of the worst things out there. But bacteria lives at multiple layers in fresh water, more so than the salt. But so getting suction, getting all that water out, and then at the hospital they're going to get that follow-up care. But definitely, if they survive the drowning, they still have to fight an infection. So especially with elderly patients, pneumonia and aspiration is a huge killer for them. So that initial ROSC or whatever may be all great, but keep in mind down the road they still have life-threatening injuries that they need to have taken care of. So, yep, you're going to provide for the airway, which whatever mechanism necessarily, and then high flow oxygen, and you're going to continue to monitor. You're going to use your assessment tools like pulse oximetry, but you're going to, of course, be looking for a good pleth and skin color if you're not getting a good pleth. Yep, you're checking for a pulse. You guys know CPR. You're not never going to give up on a cold water drowning victim. Cold water will occasionally activate certain primitive reflexes and evaluate the patient for adequate perfusion. That is something when you're rewarming them, they can develop some of those reflexes, like those respiratory drive coming back. So kind of what I alluded to earlier, we're always going to try to transport these patients due to the obvious, and then inhalation of amount of fluid can lead to delayed complications lasting for days or weeks. Do you guys remember what another injury or symptom is called after initial drowning? Dry drowning. And do we know what dry drowning is? Yeah, so water in your lungs. So it is kind of one of those beliefs that they believe that the volume, the fluid in the lungs, when you lay someone flat, that can cause more surface area in the lungs, but it can pull fluid back into the lungs. So someone who truly went underwater, maybe just breathed in a little bit of water, for a reason that body mechanism can bring in the fluid volume. There's a lot of good studies and theories on it, and but you do have to worry about that secondary drowning or dry drowning that it's called. So always be very careful when you are considering refusal on these patients. A couple articles I did read is, just parents that their kid was swimming in a pool and started to go. Some parents don't think anything of it. They let them go sleep. Their patient had basically drowned. Patient's lungs started pulling on that water, that fluid, and basically just save that kid's life because they were able to suction out and save that kid's life. So secondary drowning or dry drowning is always a concern. Yep, a history taking sample. Secondary assessment. Yep, you're checking for other complaints, signs of hypothermia. You're getting a GCS. Your lung sounds, checking heart rate. Yeah. Yep, you guys know documentation, checking every 5 minutes. Breath sounds. Yep, should be kept warm. IV fluids, transport. Yep. Yep, air embolism. We're treating with oxygen. Sounds good. So safest time to escape a submerging vehicle is immediately after it enters the water. Attempt to remove the passengers from the vehicle as quickly as possible. Sometimes, obviously, that pressure of trying to get a door open because there's no water on the other side. So obviously, when there is water on both sides, it'll start getting easier to open. But yeah, break windows, help them out. So injuries that caused by water hazards may complicate by immersion in cold water. So we're talking about boat impellers, sharp rocks, water skis, dangerous marine life, which we don't have in our local area. But other things that happen quite a bit is whether it's on the Spokane River or around Tubbs, we have a bunch of cliff divers, a bunch of kids just jumping off those rocks, hitting heads. So be be mindful that not only are you maybe dealing with a drowning patient, but maybe like a C-spine injury. So keep that in mind. And nothing crazy about the treatment that you guys don't already know. All right, so we're going to get into high altitude here in just 5 minutes. I think we're getting through it, guys. Take a 5-minute break, and we'll keep getting through this. All right, guys. So we got high altitude to talk about. Then we're going to get into some insects, some spiders. Coulter, you like spiders, right? And then snake bites. I think they have like 11 slides on snake bites. But we're gonna get through this hopefully in the next about 15 minutes if you guys are okay with that. Talk about scorpion stings, but then I think that'll be about it. So yeah, we're gonna get going. High altitude. So basically, they're starting to look at people or signs and symptoms. You're getting anything above 5,000 feet, which isn't huge. And then I believe anything about 8,000 feet, people technically could start developing that HAPE, that high altitude pulmonary edema. So any signs and symptoms caused by the difference between the surrounding atmosphere pressure and the total gas pressure in various tissues, fluids, and cavities in the body. Altitude illness occurs when an unacclimated person is exposed to diminished oxygen pressure in the air at high altitudes. And it will affect the central nervous system and pulmonary system. So the acute mountain sickness, anything above 5,000 feet, results in diminished oxygen in the blood, hypoxia, as well as the opposite will happen at a chronic, when you spend a long period of time in a high altitude, you'll have that polyhematemia, meaning extra red blood cells that'll develop for the body, so you can sustain at those higher altitudes, and that can carry more oxygen cells. That's why people like to train at those higher altitudes and then compete. Basically, that's just putting naturally more red blood cells into your body. Signs and symptoms starts with headache, lightheadedness, gets into fatigue, loss of appetite, nausea, difficulty sleeping, shortness of breath during the physical exertion, and then swollen face. HAPE, high altitude pulmonary edema. Probably another good canned question of like, what is HAPE? You know, it's that fluid collects in the lungs, hindering the passage of oxygen into the bloodstream. Signs and symptoms: shortness of breath, cough with pink sputum, cyanosis, rapid pulse. You know, where